Thank you for the introduction and very kind invitation to talk to you about a very important part of the management of rectal cancer patients, namely the staging. Not just the normal staging, but the ideal staging. So the aim is high. Let's give it a try. So, of course, we all have a common goal of the rectal cancer treatment, and that is, of course, to cure the patient. And depending on the amount and which risk factors there are, the treatment might need to be intensified. So in a very small tumor, you might only do a local excision, but if the tumor becomes larger or gets positive lymph nodes or threatens mesorectal fascia, then you might need to intensify the treatment with neoadjuvant treatment, either chemoradiation or a more intense modality like total neoadjuvant treatment. So the role of us as radiologists is, sorry, it was on my screen. Can I put it here? Yeah. Not only to provide an optimal MRI protocol, but also give an optimal interpretation of the images, and with that provide a risk stratification. We need to summarize that in an optimal report, and of course also do optimal communication during the MDT meeting. And the MRI protocol is actually very simple. It consists of two T2-weighted images in 3 different planes, namely sagittal and an axial perpendicular to the tumoral axis, and the coronal images parallel to the tumoral axis. And in very low-lying tumors, these coronal images need to be parallel to the anal canal to optimally be informed about the invasion of the anal sphincters. And with that, we advise to do some diffusion-weighted images, which are mainly important in the restaging setting. But it's nice to have to compare before and after the neoadjuvant treatment. With these sequences, it's a very short protocol, actually. You are ready in 10 to 15 minutes. And it can be performed on every MRI scanner. We need to have high resolution, so the slice thickness needs to be a maximum of 3 millimeters. And you can administer the patient some spasmolytics or rectal enema to reduce the artifacts. We do not advise to do rectal filling. And all of these recommendations were stated by the ESGAR, which is our European Society of Gastrointestinal and Abdominal Radiology, and we are currently updating the guidelines. So hopefully by the end of this year, we have a fully updated recommendations for rectal cancer staging. And also structured MRI report template. That's really important, so you can find all the important features that you need to have to decide what is the most optimal treatment for the patient. So we will go through the report template and look at all the features that we can see in rectal cancer on the MRI. So at first, the morphology. It can be a solid polypoid tumor, like this example on the left, with the stalk at 9 o'clock, a solid, more semi-annular tumor, or a mucinous tumor, and that is typically contains very high signal on the MRI, and it's really important because, of course, these patients have a poor prognosis. Then we need to measure the distance from the anorectal junction. On the MRI, it's nicely seen on the sagittal images where the levator muscle is at the level of the bowel wall, and that is actually the anorectal junction, and from there we draw a straight line to the lower pole of the tumor. And that is, of course, important for you to know if there is a safe distal margin and you can still perform an anastomosis. The upper border at the other side was decided in a consensus meeting of experts, and has now already been in use for several years, and that's the sigmoid takeoff, which is also nicely seen on the MRI, and that's on the sagittal images where the bowel courses away from the sacrum to the ventral side of the body. And it is now in use in many centers, and it is quite reliable, but there might be some issues with it. It is important to make the differentiation between sigmoid and rectal cancer, because you all know that the primary treatment of sigmoid cancer is surgery, and only in very advanced cases you might start with the chemotherapy first. And for rectal cancer, of course, it's completely differentiated and personalized for the patients. So these are quite simple examples where on the left the tumors completely located above the sigmoid takeoff, whereas on the right it's below the sigmoid takeoff. But unfortunately it's not that easy in all cases. You have some interpretation pitfalls, mainly related to anatomical variations. For example, a mass effect of adjacent organs, small bowels that are deeply located within the pelvis, or pelvic floor insufficiency. And then it also depends on the actual angulation of your images, which can produce different images. And also the tumors located at the sigmoid junction, then we need to really discuss with each other, how do we call this tumor? And now the general consensus actually is, if any part of the tumor starts below or at the level of the sigmoid junction, then we call it still a rectal tumor, because although it's a very small part of the tumor, you should still call it rectal cancer. So how to deal with these pitfalls? Of course, if you look a lot at the images, you will get better at it. If you have problems with your interpretation on your actual images, you can also correlate with the coronal, sagittal, and the images on the CT. So here are some examples of anatomical variations. Here we see a cluster of small bowel loops deep in the pelvis, and where you would expect that the sigmoids would course ventrally, horizontally towards the ventral side. It goes more along the sacrum. Here are some examples of the actual angulation, and you see that it's really different on the actual images than if you do a different angulation. And this is an example of a tumor at the sigmoid junction, but also here, because it's part of the tumors below it, I should still call it a proximal rectal cancer. Then we do some measurements of the length of the tumor, because it might have some influence on the surgical planning, and it also has some prognostic value and as a comparison to the evaluation after neoadjuvant therapy. Then for the T stage, of course, small tumors confined to the rectal wall, they can easily be seen when the bowel wall is still intact with a very thin black line, as seen in these images. But the moment the tumor grows into the mesorectal fat, we have to define how deep it grows into, because that also has a prognostic value. And we know that the bigger the tumors, the more invasive the tumors, they have a lower cancer-specific survival. T4, it's not really defined in the TNM staging, it's just invasion into surrounding structures or organs. Also, in the updated recommendations, we will get some more specific information. So, of course, growth into adjacent organs, like the cervix or the bladder or the prostate. T4A specifically for invasion in the peritoneum, but also other structures like the ureters or the nerves or any fat outside the mesorectal compartments. Sphincter invasion, I already said, it's really important to that the coronal images are parallel to the anal canal to have optimal information about which structures of the anal complex are involved, because that might indeed have influence on your surgical planning. The mesorectal fascia. It's nicely seen on the MRI. It is a thin black line that surrounds the mesorectal compartment, and of course in standard TME surgery that's your surgical plane, and we can really have a good evaluation of the distance between the tumor and the mesorectal fascia. Of course here we also need to be aware that on the anterior side in more proximal tumors, somewhere the peritoneum starts. Specifically for the radiologist, they need to not call this MRF invasion, but peritoneal invasion. And then, of course, you already have the T4A stage. We call it a positive MRI not only by invasion of the tumor itself, but also when the MRF is invaded by either EMVI, tumor deposits, or irregular lymph nodes with extracapsular extension. If we have very smooth lymph nodes, they might be enlarged, but we do not call this invasion of the MRF if they are closely related. Here are some examples. On the left side, we have a small part of the MRF that is involved. In the middle, of course, a very bulky tumor with multifocal invasion of the MRF. And on the right, we have actually a tumor deposit, which is located at the MRF high on the left lateral side. Of course, the MRF becomes less relevant if we are completely sure that this tumor is confined to the rectal wall, because then there is no mesorectal fat invasion and typically no MRF involvement. The lymph nodes, my favorite subject. No, it's really difficult on the MRI, and it remains that way. We try a lot of things to increase our accuracy, but still it is challenging. Just for the location, of course, local regional, we call all those nodes in the mesorectal fat up to the aortic bifurcation. And then all those lymph nodes either along the common iliac, external iliac, or in the inguinal space that is metastatic disease. Only if we have very low-lying tumors extending below the dentate line, then the inguinal region will still be local regional lymph nodes. And then, of course, the lateral lymph nodes, which are in the obturator space and along the internal iliac. As I said, it's really difficult. If you look at size alone, we know that's not sufficient, because around 70% of the positive lymph nodes are small, less than 5 millimeters. And it's 50-50 for the large lymph nodes being benign or malignant. So we need other features to look at. We can use the indistinct border, heterogeneous signal, or the round appearance of the lymph nodes. And if we combine all these characters, we might have an increased accuracy to make the differentiation. But we still know that we are not that accurate. So we need to be aware of that. And we might also give a level of confidence when evaluating these lymph nodes. When we are completely sure that there are no positive lymph nodes, it's still possible negative nodal disease or very definite positive disease, with the combination of the size and the morphology. And of course, also really important, which will also be incorporated in the updated guidelines, is that you also have to look at the other risk factors, because the chance of a positive lymph nodes becomes higher if you already have a lot of other high-risk features, like a higher T stage, EMVI, or a very high number of lymph nodes. If you are really not sure, please choose to go towards the downside to prevent overstaging. And of course, you need to know where those suspicious lymph nodes are located so that we can either resect them or incorporate them in the radiotherapy planning. Then there is another problem. Yeah. Okay, for the lateral lymph nodes, they occur mainly in the advanced low tumors, up to 33%. And if we have local recurrences, about half of them are lateral, and about 40% of those recurrences have no distant metastasis, so still localized disease. And of course, it's always better to prevent than to cure. This is a nice map showing all the regions at the lateral side. And in our guidelines, there are no specific criteria yet. They will also be incorporated in the next edition. But we know from multi-center research that if in primary staging the short axis is 7 millimeters or more, then we should call these lymph nodes malignant. And in those borderline nodes, you might also have a look at the morphological features. We should be aware that there are typically benign lymph nodes directly posterior to the iliac vessels. They are oval-shaped, most of the time symmetrical. But if you have other nodes than that, very bulky, then you should be aware that these can be involved. Then a word on tumor deposits. We know that it's quite difficult to differentiate them from lymph nodes, but they do have a worse prognosis, and we might suggest them if they are located along the vessels, if they have tumor tapering into those vessels, and if they have a irregular shape. And you can think of them like a disease like discontinuous EMVI. Because they tend to present at the same manner, only then discontinuous from the primary tumor. Last but not least, the EMVI is the extramural venous or vascular invasion. So you see the vascular structures. They need to have tumor signal in it. They need to be widened or irregular to be sure to call it EMVI positive disease. And it is, as you all know, associated with a higher risk on metastasis and decreased survival. So here are a lot of examples, very bulky ones, more subtle ones, but also to indicate that you shouldn't call every vessel that you see an EMVI, because if they are still smooth, not widened or irregular, then these are just normal vessels and not EMVI. So to summarize, we look at the MRI, at the morphology of the tumor, and then define the location in a clockwise manner, look at the height, mainly the distance from the anorectal junction, measure the length of the disease, define the T-stage, invasion into the mesorectal fat or surrounding structures, the presence of lymph nodes or tumoral deposits, and EMVI. So let's practice this in a case. Have a careful look, because I can only start the video and not pause it. So this is a distally located tumor near the anorectal junction with invasion into the mesorectal fat, which you can see here, also invasion in the vessels, a lot of lymph nodes, I think, tumor deposits, so this is quite an ugly tumor. So if we summarize and put it in our report, we see that this solid, completely circumferential tumor at around 0.8 centimeters from the anorectal junction with a length of 5 centimeters. It invades into the mesorectal fat, nearly 12 millimeters, so it will be a T3C. Then we have threatening of the mesorectal fascia. We don't have sphincter invasion because there was still distance. Then we have a lot of lymph nodes which are typically malignant. And the lateral sides, I'm not really sure that it was a lymph node with a short axis of 6 millimeters. It is a little bit round and heterogeneous, so maybe this can be a positive lateral lymph node. And this is a very large tumor deposit, also located at the MRF, as shown in an earlier example. And here you see the EMVI, and that was obvious. So to summarize this in a stage, it's a CT3C and 2 tumor with an invaded mesorectal fascia, EMVI, tumor deposits, and maybe a positive lateral lymph node. So in the MDT, this patient was discussed, and because it's a very ugly tumor, we need to intensify the treatment for this patient. So to take home, MRI is the best tool for local staging. It can also determine the location either in the distal or proximal rectum, or if it's a sigmoid tumor. Of course, we are able to detect all the high risk factors which have a large influence on the treatment choice. We put it in a structured report and hopefully can guide you for the best treatment for this patient, and that will all be discussed in the multidisciplinary team meetings, and together hopefully we have an optimal patient management. Thank you for your attention.